Okay, welcome everybody to another edition of the Florida EMS webinar. Today is a special edition, and this is a presentation that I've been very excited about because if any of you are in EMS and you understand the fact that patients do not always need the full cavalry to show up at their home. In fact, and you'll hear today on the presentation that many, many patients each day in all of our systems can be treated right where they're found. And with the technology that's in place, it's a big wonder, why hasn't this been figured out? And so today we have on the show two incredible people who have been doing this for quite a long time, and they have a great track record of actually figuring this quasi-complicated problem out. So today we have on the program Dr. David Persse, who's the Chief Medical Officer for the Houston Fire Department, and he's the CEO of Ethan, which we've heard about for quite a long time. We've known all the great things that Ethan has done. And today, along with Gaby Rowe, we get to hear exactly how they're doing it. So David and Gaby, thank you so much for joining us today. We looking forward to hearing all about Ethan, and then I'm sure that the crowd will have questions afterwards, but please make any further introductions and take it away.
So Dr. Antevi, Peter, we've been friends a long time. Thank you for that introduction. And yes, along with me is Gaby Rowe. She's our Chief Operating Officer. And along with her, we also have Jessica Coffey, who's a project manager, and also Brittany Sutton, who's another project manager, part of the team. So Florida is so important. We brought all of our all-stars to share with you with our Ethan program. And I'm going to basically do the play-by-play, and Gabby's going to come in with the color commentary and answer some, we've at the end of the presentation, we've got a couple of FAQs, but then we want to open it up and let y'all ask questions at the end. And with that, well, first of all, is my screen sharing? Can everybody see the screen that's got the Ethan logo?
Yeah, we can see it, David.
Okay. All right. So then I'm going to go ahead and I'm just going to go through these slides. We got about 15 slides here. Embedded in here, I hope you'll bear with us. We've got a video that is basically it's a live. Well, it's not live, but it's a demo of a case, and so you can kind of get an idea and maybe get a little bit of a feel for what actually happens. And that demo runs about 8 minutes, which is actually a little bit longer than a real life interaction. We're running about 7 minutes actually in real life, but this one runs about 8 minutes. So, anyways, Peter, you did a good job of sort of describing. I'm not going to read this slide to you. I put it up so people can glance through it. But the problem is basically what you described, that people call 911 for a lot of non-emergent problems, largely due to, and we all know, it's due to access to care issues or access to continuing care issues, things which EMS, we can't solve those problems. So it's not our problem, but it does become, it's not our responsibility, I should say, but it does become our problem. And so we struggle with this. And so our history with Ethan is we tried to address that challenge here in the Houston Fire Department. Going back to 2008, we started. And what we started with was basically a nurse helpline from dispatch. And so the calls would come in, we had pre-identified, we have a local dispatch algorithm. We don't use one of the commercial ones. We've got a local one that we've been cultivating for years. My predecessor, Paul Pepe, started it along with Jeff Clausen, ironically enough. And Jeff went and became, well, I don't know about rich, but he became famous and changed the face of EMS. With MPDS, and we here in Houston have taken Paul's version of it and just continually grown it. So anyways, we can identify those calls which we think are low enough acuity that we were able to send them over to a nurse helpline. And what we found was that, when you do that, when you contract with the nurse helpline, their nurses, those are their employees, and they have an employer who has attorneys who go over the scripts and the algorithms, and they are understandably conservative. So that they minimize the liability, which I completely understand. What we found, though, was that about 80% of the calls were coming back to the dispatch center. So some people say, well, that's a 20% success rate. And I looked at it like, no, it's an 80% failure rate. And so we were getting some calls handled by the nurses, but I wasn't satisfied with how much. So we thought, well, maybe it's just this group of nurses and that liability attitude or culture at that place. So we tried another set. Basically had the same thing. So we tried a third nurse helpline and you had exactly the same sort of results. And so again, you could consider that a 20% failure. I considered it an 80%, or you could say a 20% success. I considered it an 80% failure. So in about 2014, we changed it, and we recognized that our EMTs and paramedics, they've got a tablet that they get their dispatches on and that they do their records on. And that tablet has a speaker and a microphone and a camera and a screen. And so we set it up so they could basically video conference with an emergency physician. And we specifically chose emergency physicians because nothing against the nurses, but as an emergency physician, Peter, you're an emergency physician. I'm sure many of the people on here are emergency physicians. The one unique skill set that we have is the ability to quickly ascertain if somebody is sick with a capital S or sick with a lowercase s, or perhaps not even sick at all. And so when you get the 55-year-old hypertensive diabetic who says they have chest pain, well, that's a scary title. But once you start talking with the patient and you get some more information from the providers on scene, an emergency physician can quickly separate out whether this is something I need to worry about or I don't need to worry about. We need to get this person care, but do I need to use an ambulance for it? And do I even really need to send them to an emergency department? So that's the extra added value that an emergency physician provides. In addition, and the other side of the coin, every once in a while, you're going to get a case of a patient who has something which they are sick with a capital S, but it's really, you know what, it's not in the scope or the training for an EMT or paramedic to necessarily recognize that this person has whatever the issue is that actually does require an emergency transportation to a hospital. So anyway, so we started that about 2014, and today in Houston, we've got over 200 of our emergency vehicles. That's every fire truck, every ladder truck, every basic ambulance, every paramedic ambulance, and every supervisor vehicle have got the software on their tablets to be able to interface with the Ethan physician. And in addition, we've got about 15 physicians that we do this with. It's been very steady. We've lost one physician in 15 years. That's because his spouse got a much higher paying job at another community, and he decided he didn't need to work anymore. So he retired, and we have recently added one new physician who actually was one of our HFD doctors who has just come on, and he is an assistant medical director for one of the local EMS agencies. The thing about the doctors that we have is they all work full-time in a local hospital emergency department. These are faces and voices that our EMTs and paramedics are familiar with seeing, and they are actively practicing emergency physicians. And so, so this is a part-time job for them. We work 4-hour shifts. We do about 6 a month if you're a doc. It ranges from 4 to 10, but about 6 a shift a month. And now in 2020, for what it's worth, we moved to Microsoft Teams, and we did that for security reasons. The video conferencing is far more secure with Microsoft Teams, so we did that for patient privacy issues. But here's the big news. This last year, just several months ago, Ethan came from being completely within the Houston Fire Department to becoming an LGC, a local governmental corporation. And what that means is that we can now function like a private company. So we can now have other customers besides the Houston Fire Department. And in addition, we've got our own board of directors, we've got our own attorneys. We are a lot more nimble and able to adjust to what our customers may like than we were when we were within the fire department and within the confines of the city. Because like any other big governmental bureaucracy, in order to create any sort of change was very difficult. But we're far more nimble. And so as we look to have new customers, we recognize that things may need to be customized to your location. Here's the problem, and we kind of touched on this earlier. And again, I'm not going to read this slide to you, but we know that this is a huge financial burden on the overall healthcare system, the inefficient use of emergency services. And I don't mean to be throwing the patients under the bus. We have simultaneously in this country created a huge access to care problem. We've made it confusing for people. We put all kinds of hurdles in the way in terms of financial efficiency. And the default is to call 911 and hope you go to the emergency department and get taken care of quickly. I also point out that we have a lot of people, I say we live in a Burger King society. I want it my way. I want it now. I want it exactly as I expect it to be, and I don't want to have to pay much for it. And, so what are we doing? We're putting people in, you're going to hear me say this again in the video, but putting people in the most expensive form of transportation to the most expensive form of healthcare. We are being completely counterintuitive with the way we're doing things today. And so you can see on this slide that we predict and we got these from outside sources, that about 40% of the patients transported by ambulance are clearly non-emergency. In your community, it may be a little bit higher, a little bit lower. And even if the patients who go by ambulance, and this was the highest estimate that we could find, is about 39%, perhaps 39% require admission to the hospital. Again, either way, hugely inefficient. Perhaps $10 billion could be saved across the nation if we were to get a little bit more efficient with how we manage. And this is just EMS and emergency care.
David, I have a quick question here. Is that in the 17 or the 37,000 patients that you have seen in Houston, were you able to demonstrate? Because it would seem very easy, I think, to say that patient stayed at home, did not require any admission to the hospital, even to the emergency department. Were you able to at least show on paper the millions of dollars that have been saved here?
Peter, I think you're clairvoyant. Um,
Yes, look at that.
It was a plant. It was a lead up plant.
Wow, that's pretty good. Okay. So that was a softball right there.
yeah. Yeah. So when it comes to this, obviously the potential savings in terms of, and there's operational savings. There's three savings, really. There's operational savings, there's financial savings, and then the other thing is, and I'm gonna call it emotional savings on the level of the provider. So the savings are huge. We think that, here, if we did this went nationally, it could be, 6 million or more potential Ethan if we did this nationally, right? For the local municipality, and I'm making an assumption here. Well, let me just speak for Houston. We don't have enough ambulances. For the call volume we don't have enough ambulances. We can't hire people fast enough. We can't even purchase the vehicles at this point to meet the demand. So what it does immediately for us is, in terms of savings, is the ambulances that we have on the street today, we're not going to take any of them off the street. So our overhead isn't going to go down because we're using Ethan. No firefighters are going to lose their jobs. No EMTs are going to lose their jobs. But what we're going to do is we're going to become more efficient with them in such a way that, perhaps the fire department doesn't, well, even if Ethan being maximally used, we, the Houston Fire Department, we are still behind, but we don't have to grow the fleet at a rate that we just can't possibly do. We can't hire enough people and we can't buy enough vehicles to make up the gap that we're currently experiencing. So there's huge savings in it that way.
And actually, maybe
here's where we get to the dollars that you're just asking.
Oh, okay.
There's actually we're up to about 40,000 patients. So when I gave this presentation a week ago, or in Brevard County, I had 37,000. We've updated the slide since then. It's about 40,000 patients now. Over 90% of the time, we don't use the ambulance. Here's an important thing for you to understand. When we started off, it was probably in the 80, well, not probably, I know that it was in the 85% of the time, we were not using the ambulance. So 15-20% of the time, the doctors are still putting patients in ambulances. The reason is now up to 93% is a couple of things. One is the firefighters have gotten better at selecting what is Ethan appropriate. They have learned. And the reason is that every time you have an interaction with the Ethan doctor, it's a teaching moment. It's a learning moment. I will tell you that back in the day, Houston firefighters were not good at examining abdomens for rebound tenderness. They thought they were, but when I got to actually watch them examine the bellies, I realized they were not pressing in deep enough and they were not snapping their hands back fast enough to elicit true rebound tenderness. Today, I challenge you to find a Houston firefighter who does not know how to examine an abdomen properly for rebound tenderness. I challenge you to have a case where they're not getting a temperature on a patient who says they have a fever. There are many things that have occurred in terms of teaching, so that their accuracy in what they send us is better, their exams are better, and the doctors have also developed a comfort level with our guys' ability to examine and get a history from a patient. We're now at about 93% of the time. Let me flip it around. 7% of the time we tell them, hey guys, it's actually sicker than you think and it needs to go in an ambulance. 93% of the time we're either putting them in a cab or it's home care instructions or something other than using the ambulance. But that evolved, right? And so we have members in the Houston Fire Department, and let's face it, we are a big urban fire department of firefighters who don't necessarily they didn't join the fire department necessarily to be on the ambulance. But I'll tell you what, we've got guys who use it all day long. They love it. And we've also got, quite honestly, a couple who's like, oh, I don't want to use that dang thing. Those tend to have hairlines and hair color like me. The guys look a little bit more like you, Peter. They are gobbling it up like crazy. So the money savings of Houston has the calculations, and we'll get to this in a moment about how we came. It's about $25 million in savings to the city of Houston.
And I want to jump in for one other thing on some of the reason why we're seeing that increase and we're continuing to see that number go up as well is the firefighters have great more faith in our transportation ability. The increase of the rideshare world has been a real boon for us. And we have moved Ethan over from independent taxi companies to now working with Uber and Uber Medical, and have had just incredible success in their showing up and their transporting in a very efficient, regular way.
And just to kind of close that loop, Gabby and David, what you're saying is that it's integrated into the system so that
Correct.
as soon as you decide Uber is needed, it's boom, press a button, and then
Our system is set up where the patient is geolocated. Uber is integrated into our system, and it is actually the Ethan doctor and our transport coordinator who is calling and managing the Uber vehicle to get to the patient.
Wow.
Yeah,
Okay.
basically all I have to do with Uber is choose the destination, and here's the other thing, I have to choose the time, which is almost always now. We'll talk about this in a minute, and then which hospital am I sending him to, or which clinic, or which urgent care am I sending him to? That's all I got to do, and then I just hit send.
Right, and all of that is actually on a visual map that the doctor is looking at, and you'll see more about this in a minute, but they actually know exactly what clinics, urgent cares, facilities are near the patient and have available appointments. That's all right on their screen for them. So they can do this very, very quickly and move on to the next patient.
Wonderful. And I guess you guys will talk about it later, but when you go to next community, all that is just preloaded in for that community. Beautiful.
Yep. It's all and it's, fortunately the way the software is set up, it's just about loading in a database of local resources, but the system is all there.
Great.
And so the other thing is that every time you use, if you're on ambulance 1 in the city of Houston, every time you use Ethan, you generate about 45 minutes of free time. So if I use it twice a day, that's an hour and a half of free time. Now, quite honestly, we're a busy system, so you're probably going to get another call. But here's the other thing. So in Houston, we have to rely on our heavy apparatus to fill the gap when an ambulance isn't available. So by increasing the availability of the ambulances, we decrease the need to be sending heavy apparatus on lower acuity EMS calls, keeping that heavy apparatus in service for the fire calls. And so it is not just about EMS. It's about the extended emergency response system for the Houston Fire Department.
Now, David, can you go back one slide, because because you said something that was that struck me, which is you said that a community is going to have to decide whether they have to buy more ambulances to fix the problem, right? Or do something else like this. And the actual arbitrage there of the amount of money that it would cost you is obviously significant. So can't each department just look back at their data for the last 12 months and they can say this percentage of patients could have required or could have utilized Ethan, and therefore now our true transport volume is this much. And so that, like, all those numbers make sense to me, but I guess we can talk about it later in the Q&A. What are the forces that are fighting against that, and who want more ambulances, and who want, in other words, and I'm thinking kind of people out there who think that we need to buy more ambulances to take care of this problem. And I think that's the mental shift that I would love to talk about afterwards.
Yeah. So well, again, now you're using the most expensive solution,
right,
to create the most expensive transportation to the most expensive form of healthcare. So you can solve it that way. Sure, you can do it that way. You can buy more ambulances and hire more people. Yeah, go.
But I think to Dr. Perse's point about the city of Houston, the gap in need for ambulances is so wide that it's almost impossible to even find the significant enough number of personnel, and train them to be able to run all the ambulances that we would need to begin to fill that gap. And as we talk to more municipalities around the country, many are facing the same issues. It's not to say that you're not going to get new ambulances. It is that you're not going to be able to get enough new ambulances. And you're not going to be able to get them online and get enough people to be able to operate them efficiently and effectively.
In fact, this bottom line here, the red part, this actually comes from the fire chief. The fire chief has been saying to council members and to the media about Ethan is a critical function of the Houston Fire Department now, because we're now down to only 300 firefighters short. So we were at one point where we were up to 600 firefighters short, and they've made some gains on that. We're now down to only 300 firefighters short. So it is a critical function of the Houston Fire Department. The fire chief said he can't survive without it at this point. Wow. So yeah, so this is, you probably already figured this out, but the call is placed and EMS is dispatched. They get on scene, the EMTs or the paramedics, they assess the patient. And here's an interesting thing. So on your tablet, you get your dispatch. You have a patient care record that you're going to fill in. Well, guess what? The dispatch information goes into your patient care record. So the dispatch location, your dispatch time, your out of shoot time, your on arrival time, all that stuff, it's all automatically loaded into your record. So when you get there, you have to start adding things, right? So in Houston, we'll take your driver's license, and there's a little magnetic strip thing, and we zip your ID or your driver's license. That populates your record. So now I got your name, your date of birth, your address, all that. Now all I got to put in is a little description of what your chief complaint is. I'll put in your vital signs. On the tablet, you basically, it's a two-step thing to get to the doctor. One is to call the doctor on Microsoft Teams, and then the other is to upload your EMS record into my record. So now when it comes to me as a doctor, my record, and I'm going to have a record, it's already pre-populated with everything. And as Gabby pointed out, that parts of that then go over to the transportation part. That's part of our proprietary software thing. So I don't have to ask the same questions all over again. I've already got it all.
And we also have built into it manual overrides. So if, for instance, you don't have that swipe of the driver's license, if there is the need for clarification of address so that transportation is actually sent to the right place, the doctor has the ability in the system to do manual override or addition to the information as well, just to make sure we get it right.
Right. So as the crew calls me, and I'll, what I do is I make sure I got the right record. I just confirm, okay, so this is ambulance 1, you're at 123 Main Street. Yeah. Okay, I see you're with Peter Antevi. Is that right? I say, yeah. Okay, ambulance 1, tell me your story. What's going on? And they then tell me, and very often I make it my practice. I always look and talk to the patient just a little bit, just a picture's worth 1,000 words sort of thing. And I'll talk with the patient real briefly. But meanwhile, pretty much within about 20 seconds of the EMT talking to me, I'm getting a pretty good feeling as to whether, hey, doc, he called because, he's out of his metformin prescription ran out and he can't get it refilled until Monday and he wants to go to the ER. So I'm already on the touch. I'm already touching getting the Uber going. Now I just got to, okay, so the address is 123 Main Street. Yeah, is that and then I'm looking on the camera because that's the White House with the black shutters and the red door, right? Which I might choose to type in to make sure the Uber stops in front of the White House, whatever I want to do. That's all occurring simultaneously, because what I want to have happen, and what happens not infrequently, is by the time I get done talking to the firefighter, he's got everything he needs for his record. I got everything I need for my record. It's about 7 minutes. The Uber is pulling up. So gotcha. So that gives everybody a comfort level. So anyway, and we got a demo, so I won't go too far into it, but just to give you an idea. So the EMT in the field, they call us. The doc makes the disposition. Again, we can go to the hospital ER if that's where you want to go. I'm going to get you somewhere. I'm not going to deny you care. But if we want to go to the hospital ER, you can. Now, I might try to tell you that we go to a freestanding ER, you're going to get seen a whole lot faster. People like that. I may tell you that if you go to an urgent care center and you've got insurance, not only you'll be seen quickly, but your insurance is more likely going to cover a greater percentage of it. I don't know your insurance. But generally, when you go, the copay is less at the urgent care than the ER, people like that, and you're going to get a free ride. Oh, sign me up. The patients are it's a Burger King society. I want it my way and I want it cheap. So you can get me seen faster and for less cost. Yeah.
So my question for you, you guys have been doing this for a long time in Houston. What have you noticed, or have you noticed a change over time in this? Because this is actually, this is different. With here in Florida, when you call 911, people are expecting an ambulance, paramedics, and a ride.
Yeah.
All of a sudden now they're getting a doctor, they're getting an Uber, they're getting options, they're talking about insurance, you're giving them ideas. Have the patients been reacting in a positive way, or are they saying, I'm not going in an Uber?
I think that the one thing to remember is there's that education process as well. And as much as they're used to dialing 911, getting in an ambulance and going to the ER, they also know that when they get to that ER, they can expect some wait times. They can expect that it is not an easy, seamless experience. When one of the doctors says to a patient, well, you know, this isn't a major incident, you're probably going to fall low on the priority list and you may have to wait for a number of hours before somebody is
Mhm.
going to see you. However, there's a clinic 2 blocks away from your house, or there's an urgent care or freestanding ER 2 blocks from your house. I'm going to get you over there. I'm going to pay for it. And they have an appointment for you within the next half hour and they're going to
Mhm.
see you right away. People
Right.
understand that.
It's
They
all about the it's all
respond
about
to
the
it right away.
communication. Right.
Yep.
And because I want to keep this conversational, Dr. Lozano from Tampa asks, what are your EPCR and MIH documentation vendors? That's question one. And then B, does it matter
Yeah.
at the end of the day? This integration is what he's asking about.
And I'll let you go, Dr. Persse, but I would say we can integrate with all of them.
Okay.
Yeah.
Meaning that the integration can be built, or the integration exists currently with some, or in other words, you would have to go to the ESO image trends, you know, and say, hey, we want to integrate. Basically.
We are currently fully integrated with ImageTrend, but we have set up the portal so that it will work with any of them. And they have APIs. We have talked to them. They all have APIs, and it's all set up to integration. It's very simple integration, actually.
Yeah.
Perfect. And then let me go to Sam real quick. Do you have any data or insight into the reduction of nursing home related calls with the use of Ethan? Because obviously many of us struggle with those. Any quick response to that one?
The reduction in nursing home related calls?
Mm-hmm.
Yeah, or similar like sniffs, meaning as far as transport. Sam, is that what you meant, Sam, as far as the transports from those facilities? Oh, let me let you unmute. Hold on a second. Go ahead, Sam. Sam, can you unmute? There you go.
Yeah, absolutely. Both transports, especially for the classic scenario, labs come back at 2 o'clock in the morning. The nurse assistants there don't know any better, so they immediately dial it as a 911 call. And with a dispatching algorithm that's not that sophisticated, it goes out as a 911 call, be it a hypertensive emergency, whatever the case may be. Clearly, it doesn't require an engine and a paramedic unit.
Yeah. So that'd be a perfect call for Ethan.
Yep.
And here in Houston, we would use Ethan for that. I can't say that it has reduced the nursing home from calling us, but it has got the ambulances and the fire crews back in service a whole lot faster. Now, within the Houston Fire Department, we have a separate group that deals with frequent callers and frequent call locations. So the fire department has a team, and they will go out there and try to work with them to reduce the calls. The other sort of a tangential question that's probably come up is what we have not created. One thing I was fearful of, we have not created a subpopulation of people who call 911 wanting that cab ride, wanting that free cab ride. We've not seen that.
Interesting.
We've got, I mean, I'm excited we don't have it at all. We've got a couple of them, but this is a city of 2.5 million people. And we've got a couple of them. And what we do is when we have somebody who's called and used Ethan 8 times, then we refer that over to the fire department's other team because their threshold is 8. If you call 911 8 times in a year, you get on their radar. If we find somebody on our radar that's called more than 8 times a year, we send it over. We don't generally send many over because we don't get people call asking for Ethan 8 times a year. And quite honestly, they would have been caught by their filter first anyways. But we did not create a subpopulation of people calling for a free cab ride.
Yeah, and what we've found in that is if somebody says, I don't want to go to the clinic 2 blocks from my house, I want to go to the one all the way across town, which it is 99% of the time because they actually want to ride all the way around across town, and we refuse to do that. We say, look, we will send you to the clinic 2 blocks away. We have had people stop their Uber ride when they realize they're not actually going to get taken to the other side of town, despite the fact we told them that, and get out of the Uber. But those are very, very far and few between.
Yeah.
Before I get to Dr. Landry's question, when that person is in the Uber, does someone have visibility to see, oh, the Uber went from here and actually stopped there and patient got out and we're good?
We fully track the location where they are, where they're going to, when they stop. And we have a recorded record of that so that we actually have a safeguarding person who checks through all those records. And we have a member of staff who, if there is some kind of an incident, reaches out to the patient the next day and finds out what happened.
Perfect.
If it's
So
not
that
clear to
happens.
us from the record.
So is that 100% of follow-ups? 100% of patients gets follow-ups as far as the
100% of the ones where there's not a clear record that they were dropped off and went to where they were supposed to.
Gotcha. Okay, but how about if a patient had an issue, you called in a prescription, and let's say they didn't call in the prescription, that wouldn't be known to the team, right? In other words,
No.
Okay. And let me bring Dr. Landry in. Kim, go ahead, unmute yourself and ask it. Dr. Landry from the Panhandle of Florida. Go ahead, Kim.
Hey, good morning. Yeah, so I've been dealing with telemedical patients for many years right now, and so I guess my question is, are you finding patients abuse your Ethan system in terms of, I'm not feeling good today, I don't feel like going to my primary care doctor. Let me just get Ethan to come check me here at home, because if all I need is a prescription for this, they can email or e-prescribe the a medication for me. So, are you seeing much of that in your program?
Yeah, no, that's what I was getting at a little bit earlier,
No,
but
not
no,
at
we
all.
really not. We expected that we would, quite honestly, but it hasn't happened. We've not seen it. So I don't know. Yeah, I mean, I'm still bracing, but it's been over a decade now, and I'm still bracing myself, waiting for it.
Right. And I know that we're going to end up, because we've talked about it in the past, get to the revenue section of this, meaning like, the fire chief sees this potentially as a loss of revenue. And I know we'll probably get to that question, but I'm sure people are thinking about that, because especially here in Florida, that's what the fire chiefs kind of depend on, that revenue.
Yeah.
And I'm curious, at some point we can talk about that as well.
We will. We'll talk about that. But getting back to one of your other questions I was sort of anticipating coming up is here in Houston, the city attorney has backed up Ethan and basically said that, when somebody calls 911, they've declared an emergency in the city of Houston, and the city is sending professionals there to mitigate that emergency. So just like when your house is on fire, you don't get to tell the fire captain how to put out your house fire. When you call 911 for an ambulance, if the doctor gets online and says, you don't need an ambulance, we're going to put you in this cab and we're going to get you to an appropriate place of healthcare, you don't get to demand the ambulance. Now, Peter, for you and the folks on, the way I handle that, when I'm the doctor on duty, the way I handle that, if I get somebody this goes to your question about somebody demanding, the ambulance, I will tell the EMT or the engine captain, say, listen, Captain, I am willing to hold the line with them and tell them, no, you can take the cab or not. And I will have that conversation with them. But quite honestly, sir, you're the one who's going to be on scene. They're going to be yelling and screaming at. You tell me what you want me to do. I'm happy to do it, but if you don't want to deal with them yelling and screaming at you, I've had sometimes they say, Doc, I don't want to deal with that screaming. I'm just going to let the ambulance come in. That's unfortunate. That's not efficient, but that's their call. I allow them to make that decision. They're on scene. They're the officer in the department. I respect their decision. I've had more often I said, oh, heck no. This guy, forget it. No way. He's going in a cab or he's walking. You hold it. You hold the line, Doc, and I will. But I'm very professional and nice to the person. I explain to them, we need that ambulance. We're short ambulances across the city. You have an urgent medical need, which we will address with a cab to an urgent care center or wherever you want to go. But we have got to get that ambulance back in service. So here's your option. And we've been doing this a long time. That is not a common conversation. That is an uncommon situation when we get to that point. But that's how I handle it.
Gotcha. And that's great kind of tactical advice. And I think many of us who take phone calls all the time, we know exactly what you're talking about. Going back to the step-by-step process here, can you give us an approximate amount of time that this loop takes from the moment that the medic says Ethan patient until they're actually gone from the scene? Do you have that?
Yeah. So we're going to do the demo in just a moment. So let me go ahead here. We'll get to that. I've talked about this before. We don't just send people to to hospital-based ERs. We send them to, well, actually, we send them to hospital-based freestandings as well. And here's why. Because there are a lot of non-hospital-based freestandings in Houston, but they don't necessarily fall under EMTALA. So if we send somebody who doesn't have the right kind of insurance to a, St. Peter and Tevi's ER, they could just turn around and generate another 911 call. Well, that's counterproductive. So we only send them to hospital-based, and there's plenty of them in our urban center. We send them to urgent care centers. Now with those, I don't ask for their health information, their health insurance information. I just confirm that they've got health insurance for the same reason. The urgent care center will take care of pretty much anybody who's got almost any kind of healthcare insurance. But if they don't, they're just going to call 911 because, oh, the fireman put you in a cab and sent you here. Well, good. Then the fireman can take you to the freaking hospital, right? So,
Right.
So I just make sure they have any kind of insurance. So I don't ask it. I don't, any policy number, group number, none of that. It just, do you have insurance? Do you want to go to an urgent care center? We have the federally qualified healthcare centers, which will take people who are uninsured. And then in addition, we're really lucky here in Houston. We've got 6 behavioral health clinics. And this is important for our community. And I would hope that anyone listening that in your community would have this. If I send a schizophrenic who's off their meds for 10 days and is hearing voices again that are not yet threatening, but I know, or the patient knows that they're going to get threatening and scary if I don't get back on my meds, and all they need is a medication. If I send them to Houston General Hospital, they'll leave there with a prescription for their antipsychotic, which they're not going to be able to get filled. If I send them to one of our behavioral health clinics, they're going to leave with a 5-day supply of medication and a clinic appointment within the next 5 days to return and start care. So that's a huge game changer for us when it comes to the behavioral health patient, because I get lots and lots of, I mean, it's the most common behavioral health patient is not somebody who's depressed. It's a schizophrenic who's off their meds and they know what's going to happen if they don't get back on them. So, not a big.
But it's important for each community that we go into. We know that the range of resources that are available are going to be completely different. So the way the platform for the doctors is set up is all of those resources get loaded in, and we interface with those resources locally to introduce them to Ethan and to find out what their availability is for us to be directing Ethan patients to them. We don't just, put them on a map and say, oh, well, they'll just go show up. We actually interface directly with those urgent cares, those freestanding ERs, those clinics, and develop relationships with them so that we know exactly how many patients they want to see, and all that gets loaded into the system, and we stay connected with them over time if that needs to ratchet up or ratchet down based on what they're observing.
Got it. Beautiful.
All right, so let's go and let's show you a little demo here. You will now see a reenacted demonstration of how Ethan Health works in the field.
Hello,
Hi, how are you?
my name is James Sheffield. I'm a paramedic with the Houston Fire Department. I understand that you called 911 today.
Yes, I'm having a severe pain in my arm, my fingers, and it's radiating to my arm.
Okay.
And it's just a lot of pain.
Okay. Has this ever happened before?
Yes, on and off, but not as severe as today.
Okay. Have you ever been diagnosed with any problems with your arm? Okay. I'm going to check your vitals real quick, and then we'll go from there. How's that?
That's fine.
The good news is, we can definitely get you some help from that. We can take you to the hospital if that's what you prefer, but there's other options out there. One of the options is I can get you on a video conference, one of our doctors. He can talk to you, maybe provide you a little bit more advice that I can give you.
I prefer that. I don't want to go to a hospital.
Okay, very good. I can do that. I can get him on the line, and we can go from there.
Hello.
The EMS medic completed a standard field assessment to determine the patient's condition and level of acuity. Since the case is non-emergent and the patient agreed, the EMS team will initiate a secure video call with an Ethan Health physician directly from the scene.
Thank you for using Ethan. Please stay on the line while we connect your call.
Yes, sir, Dr. Persse. This is James Sheffield on Medic 8. I have a patient that I think you'd like to talk to. Her name is Sandra.
Hi, I'm Dr. Persse.
Hi, I'm Sandra.
How can I help you today?
I'm having pain in my fingers, and it's radiating up my arm.
Can you raise your hand up so I can see it? Again, then can you point to where you're feeling the pain?
The pain is here and here, a lot of around my wrist area and forearm, and I got a lot of numbness, a lot of tingling, and it's just very uncomfortable.
What were you doing today when it started?
I was typing on the computer.
Okay. Do you have it in the other hand?
No, it's mostly on the left arm.
Okay. How does it feel right now?
It just feels very sore.
Oh, let me ask you, do you have any other medical problems I need to worry about? High blood pressure, diabetes, anything like that?
No, sir.
Okay. And have you seen a doctor for this problem before?
No.
Okay. All right. So
No,
you're
today the pain was just super strong.
Okay. All right. Well, we can do a couple things. It doesn't sound like you need an ambulance, so we can get you to healthcare. We can do it one of two ways. I can get you to a hospital emergency department, or we could get you to a clinic. It's daytime. The clinics are open. I have the ability to get you an appointment for a clinic appointment, say 30 minutes or an hour from now, and we'll get you a cab ride there as well.
Yes, I prefer the clinic. It's a cheaper route to go.
Okay. All right. And so let me talk with the firefighters, and we'll find out, do you have a particular clinic you like to use, or do you want me to find one that's nearby for you?
One that's nearby.
Okay. All right. Let me talk with the firefighters, and we'll get this going. We'll get this going for you. Okay.
Thank you so much, Dr.
After the Ethan physician evaluated the patient through telehealth, instead of defaulting to an ER transport, when applicable, patients are guided to the right level of care, whether that's a clinic, urgent care, telehealth follow-up, or home care, ensuring faster, safer, and more efficient outcomes. Did you get a set of vitals on her?
Yes, sir, I did. Her blood pressure is 130/70. Her heart rate is 64. Her respiratory rate is 16. And she's sitting at 99% on room air.
Okay. Did you find anything on physical exam I need to be worried about?
No, sir.
Okay.
Looking at
Did
both
she
hands,
feel
they
no
both look the
glucose?
same. They both feel the same. She has equal grip strength in both hands. The pain seems to be, confined to that one hand, and the pain goes up her arm, but it's non-reproducible by me pushing on her arm, moving her hand.
So I'm going to find a clinic in the downtown area. There's going to be the Hope Clinic is not far away, and I'll get a cab set up for now, and we will get it going. Now you put a cell phone in the record. Is that a good cell phone number for the cab driver to call her?
Yes, sir.
Send her a text if he needs to.
Yes, sir.
Okay. All right.
Your ringer's on?
Yes.
And she'll be going by herself, right?
Yes, sir.
I'm going to go ahead and book this cab, and we're going to get you a booking number, and I'm going to put it in the chat for you, okay?
Yes, sir. I got it
Okay.
right here. Yes, sir.
She'll need that booking number. Let her know that when a cab picks up the run, she'll get a text from the cab driver. She may or may not get a phone call, all right? But if she gets a phone call, it'll be a number she doesn't recognize, so she needs to answer that call.
Yes, sir. I'll help her get her stuff
Okay.
together, and we'll get downstairs.
Okay. Anything else I can help you with?
I don't think so. Is there anything else
No.
that you think that we
No,
need to do?
no, that
Oh,
will
you're
be
good?
perfect. Yes.
Okay. Yes, she says she's good. We're ready to go.
All right. Thank you.
Yes, sir. Thank you.
Okay, so that ran about 7 minutes, which is about how long. Now that we had a bookends with some information there, but an average call in real life runs about 7-8 minutes. And that one Gabby, just occurred to me, since we've introduced Uber, we probably need to update that video because the booking number had to do with our old taxi company. Now what they'll get is they're going to get, on their phone, they're going to get a link to Uber. Even if they don't use Uber, they're going to get a link. And they're going to be able to chat with the cab driver, and they're going to get the map showing where the vehicle is. I, as the doctor, it's a 3-way chat. I can chat with the cab driver or the Uber driver as well. What I frequently do is when we get it, as soon as the Uber driver picks up, I tell the crew, hey, he's at the Southwest Freeway and Bissonnette. And so they know where that is. And oh my gosh, he'll be here in 3 minutes. Yeah. So anyways, the other thing that we talked about earlier is that now that we've transitioned to an LGC, we can now work with other communities besides just the city of Houston. It functions as a not-for-profit. So there's going to be low cost or almost no cost to the municipalities and to the EMS provider. And we have the agility now to adapt or to customize to whatever your local needs might be. And and so that's probably the big news. And so we did load in a couple of frequently asked questions. So how does it impact your income stream? And Peter, you talked about this earlier. Fire chiefs can be worried about So the one thing to keep in mind is that for many of these calls, at least with Medicaid and Medicare, in order to get in and out of a vehicle, you don't meet medical necessity criteria. So it's not that you're losing the ability to bill, you're losing the ability to inadvertently commit Medicare fraud. So I know about you, but I've been here for 30 years, and we've had a couple of times when the federal government has come at us and said that we transported people and charged them when we shouldn't have. So there's that.
Yeah.
The other thing is that when it comes, so the numbers in this second question, how can Ethan save municipalities money? So for the Houston Fire Department, they use the values that for a heavy apparatus, it's $850 an hour it costs the city to put that ambulance or that heavy apparatus in service. And for the ambulance, they use the number $425. And that goes to, they put everything into that. I mean, it was a laundry list. I looked at it. Everything went into that. So those are the cost per hour. So when you put an ambulance back in service 45 minutes sooner, you're saving almost $400 every single time you do it. And with a heavy apparatus, it's even more. And so we use the heavy apparatus a lot. But remember, I talked about this earlier. We unfortunately use the heavy apparatus a lot to cover for the shortage of ambulances. So this is a true statistic. In the city of Houston, when we send heavy apparatus out on EMS calls, about 28% of the time is because we think we really need them. The caller has described some person not conscious, not breathing, terrible car accident, whatever. We think we really need them. We got to get somebody there quick to do things important. 72% of the time, it's because there's not an ambulance available to make that call.
Yep.
So what?
Okay. I'm sorry, Dr. Persse. I would just say there was an interesting question just popped into the chat about scheduling. When we're talking about making these calls, and it's not just being able to save on these calls. Sometimes it's the timing. What do you do in the middle of the night when these clinics and urgent cares may not be open? And what we do here now is we have a schedule for the next day. And we say, okay, I have an appointment opening up at 9:15 tomorrow morning at the clinic that is right near where you live. I'm going to book you in for that appointment right now, and you'll get a notification about it. So we do have the ability to do that.
And the Uber will show up 30 minutes in advance.
Correct.
Oh, wow. Wow.
We could book all of that through the system.
Brilliant.
Yeah. So I can't make because I'm sharing, but I can't see the chat. So let me know.
Yeah.
I decided to pop it and monitor. So
Yeah. So the actual kind of most interesting part about all of this is the fact that it's low cost or no cost to the EMS system, and I think that perks up a lot of our ears. And so, could you delve into that a little bit for all the people listening who say, "My goodness, why would I say no to that?" Right? So, can you explain that?
Yeah, so I'm gonna let Gabby go into the details, but basically we recognize that the third party payers are the ones who are saving the huge amounts of money. So we work with them, and it's a shared savings model.
So what we can say is we do not bill. What we don't do is we don't bill patients. Ours, the share savings model is based on volume and data. And we are a municipal entity. We are a nonprofit. The purpose here is to make this a low cost to no cost tool to the municipalities and have the savings, the shared savings come from the people who are really saving the most, which are those third party payers. But that does bring us to volume is what gets us what we need in order to be able to do that. However, we have to start somewhere. So we are right now looking for municipalities that would like to run a pilot. For us, the best way to approach this is doing it on a very large group of municipalities or on a statewide basis. But we want to be able to demonstrate the flexibility of the program and also understand the needs of market. So in each market that we're going into, we're looking for municipalities that want to do that pilot, and we will set it up and begin to run it in a way that really meets the needs of that community, so we can understand what the broader needs may be across the greater area.
Yeah, I think that's I think Florida is ripe for that, really, because I think we have had a discussion in the past, but for the people who are listening today, as a medical director for some municipalities, there are some rules, meaning there's an ordinance in Coral Springs, for example, that says the patient, when they call 911, they cannot get billed by somebody else,
Mhm.
right? So that automatically cuts out the ability to use any third party that's billing the patient, and that's how they make their revenue.
Yep.
So
But
this,
we do not do that at all. It's nowhere in our model. We understand that. And it isn't just, um, that's not just in Florida. There are many states where counties have enacted those kinds of rules. We are set up to avoid that.
awesome. We're coming up on time, and we're going to go over a little bit because I apologize, but yeah, David, go ahead for these.
No,
If you have
it's
another
pretty much at
slides.
the end of it. We're at the point now where we're looking, as Gabby pointed out, we're looking to find communities that are willing to take a chance on us. And so, like we said, earlier, is that it's low cost, no cost. There's generally going to be like a setup fee. For this, we're looking to see if, we'll work with you, and we will. I don't know, Gabby, shoot me
Yeah,
whatever.
we're gonna
Yeah,
minimize that
whatever.
as much as possible. I mean, what that setup fee is, it's that database building of all of the resources that are available in your community, making sure that we have developed a really comprehensive list of those and that we have built those into the interface that the doctors use. There is some labor and cost that goes into that we will not be able to cover, but we're talking about really de minimis. And as Dr. Persse said, we will be very flexible on it. We very much want to see this product in use in municipalities, and those pilots are an essential part of our journey.
Yeah, the key for us is we got to have the volume so that we can then get our real payer source working, right? And the other thing is, not only do we need to find out in your community what where the landing pads could be, hospitals, freestandings, urgent cares, what does your local transportation network look like, and Uber, Lyft, so on and so forth. But we're going to be, hiring your physicians from your community. What ideally what I want is, what I think works best, I should say, are physicians that your EMTs and paramedics are used to seeing in the ER. There's already a level of respect there. There's a level of understanding. There's a familiarity. I want to use your doctors that your EMTs and paramedics are used to working with. And quite honestly, and ones that they like working with too, right? I mean, I was an
Yeah.
EMT. I remember that there was oh my God, Dr. So-and-so is working. Let's not go there, right?
Oh yeah, happens here too. Yeah, for sure.
So
Um,
you got to have the right disposition to be able to coach the EMTs and paramedics, make them feel supported. Why not make them feel? Let them know that they are being supported and that they're doing the right thing.
Excellent. We have a couple questions coming in. So Nana Vega. So Nana is our MIH medic in Davie, Davie Fire Rescue. Nana, you want to unmute and ask your question? Thanks for coming on.
Yeah, I was just wondering if, like, I know that you were saying that there's a way for them to track the ride that they got on it and to chat with the doctor and everything like that. But I was wondering if there's someone at that urgent care or clinic that actually helps the patient out of the Uber or the ride to make sure that they made it inside the clinic.
Yeah, so generally you have to be able to get in and out of the Uber on your own in order to be done, because we recognize that certainly at the hospital emergency department, there's not going to be anybody who's going to come out and help you out. So one of our rules here in Houston is they have to be able to get in and out of the vehicle either on their own, or if they have a family member, if they need help and a family member goes to them. But I can't count on somebody at the the firefighters will help you get in, but I can't count on anybody at the destination necessarily to get them out. So that's how we handle that currently.
Yep.
And I want to bring Tanner in a minute. Let me just go to Kim's last question here. Are your telemedical physicians paid to be on call or strictly on a per patient call basis?
No, they're on call for shifts. They work
The 4-hour shifts.
They work in 4-hour shifts, correct? Just like they would if they were in the ED.
Perfect. Tanner. So Tanner, my co-host, is up in West Virginia, and I would love to hear your thoughts and any questions you have for the group.
Oh, thank you very much for coming on and sharing this with all of us. I'm blown away by the efficiency of this system and how it seems to, solve a problem that we've all faced, right? Of these low acuity patients who kind of we know in our hearts, right, that they probably aren't going to benefit maximally from just being dragged to the nearest emergency department. I just think this is a wonderful solution to a problem that exists. And I was actually reading a paper the other day in pre-hospital emergency care that was kind of describing some of the failures of ET3 in New York City, and they cited your program as kind of one of the great success stories of telemedicine and EMS. So I've two questions for you. So first of all, after implementation of this in Houston, did you see any changes in system-wide metrics like response times to high priority emergencies or time to defibrillation for cardiac arrest patients, which I'm sure you monitor in the city of Houston? I know it's kind of hard from a causal inference perspective. I'm just curious if you tracked any data related to how implementation of this program changed system level performance, looking only at ALS emergencies.
Yeah.
And then secondarily, I'll also ask, on this webinar, we talk in terms of implementation. One of the things we talk about frequently is like the deployment of pre-hospital blood is a big one, right? And in those discussions, we're always talking about, kind of the stakeholders you want to consult up front, right? So you have to have your medical director, your EMS system administrators, your ED physicians, trauma team members, right? The surgeons, if they're going to be in the trauma bay, as well as, the people from the blood bank, hospital administrators. There's a laundry list of stakeholders that kind of have to be contacted in order to get the ball rolling with these sorts of initiatives. So kind of if you have a motivated EMS agency and a medical director that wants to do something like this, do you have a resource that lists those people that we need to get in contact with? Who's the number one person we have to contact once we make the decision this is something we want to do?
All right. So let me answer the second question first because I already forgot the first one. So the laundry list of people to contact. So yes, there is, and you need to, every community be a little bit different. Here in Houston, obviously, the fire department administration needed to be, brought up to speed with it. It really came from the medical director's office, working with our EMS supervisors who were so frustrated with these non-emergency calls and us running out of ambulances every day, right? So it really started at a grassroots level way back in 2000, whatever it was. The fire department administration needs to get on board. The union needs to get on board. The mayor's office needs to get on board. Council members need to get on board. Ironically, when we worried about the hospitals because there were people who were saying, well, you're going to be stealing business from the hospital ERs, and when you send them to these other locations, the hospitals will get upset. And I'm thinking to myself, well, I know my friends in the ER aren't going to be the least bit upset, right? Because 10 less non-acute patients a day, oh, hurt me. But we did go to the hospital administrations, and they were like, why are you bothering me with this? Fine, good. I mean that. We're, at the end of the day, they got such huge problems. So the hospitals didn't have an issue. The only thing that we wound up having an unexpected issue with was, and which we've solved, was when we go to the urgent care centers and we send somebody there by cab, the urgent care centers said, well, now they've got to get home and they want me to pay for a cab for them to get home. So with the urgent care centers, said, fine, we'll take care of that. So now the urgent care centers, they've got a way to get an Uber at our expense. It's like, okay, so we're going to spend another $15, but we've still saved so much on the EMS end. And if that person's insured, we're making, it's like, I'm not going to argue over that. So we solved that problem.
Yeah.
Now you go to the ER, you go to hospital ER, I'm not getting you home. You wouldn't have done that had you gone by ambulance.
Right.
But if I can get you to go to a urgent care or to an FQHC, then okay, I'll get you home.
So it's fascinating, and I think Tanner alluded to it, that it all depends on picking the right patient, because when you do pick the right patient, it feels like a win-win-win across the board, even to the hospital who knows that they're not making money on the patient who just needs a prescription anyway.
Right.
And you're not committing Medicare fraud, right? So you're not transporting patients and God knows we are transporting people all day, every day. We have people who call us every day or every other day. We have a guy who has called us 90 times in the last 6 months. And he doesn't need to call us. So I think we all have this kind of inclination that, and it's unfortunate that we only get paid when we transport. But the truth of the matter is, we have a 25% refusal rate here in South Florida, 20 to 25% refusal rate anyway.
Mhm.
And those patients are not getting any advice. They're not seeing a doctor. They're not getting a prescription filled. They're just getting a sign here and good luck.
Mhm.
So even for those patients, the 20 to 25% of patients that we do see who could gain value from having been seen by someone who could actually give them a clinic follow-up, write them a prescription. I think there's a lot of value. So early on, when we were trying to pitch this to our fire chiefs, we were saying, we're not taking away revenue because we're only going to be addressing the 20 to 25% of patients who aren't going to get a transport anyway. And isn't that better care for the community, right?
Mhm.
And I think that's kind of the way that's a little bit of that open doorway that everybody could walk through. Now, then the other question I have for you is, um, did you ever consider doing this right from the 911 call?
So,
Well, right
okay.
to you. Yeah.
Yeah. So, remember, Tanner had a first question. We need to get back to his first
Oh,
question.
yeah. Okay.
Yeah. So to answer your question, Peter, so we are actually in the process of developing that right now here with HFD to be able to go back and have the calls routed from dispatch to the doctor. The twist on that is that the caller needs to be calling from a smartphone so that we can send them a link so that they can video chat with the doctor. I don't know what percentage. It's got to be over 90% of the 911 calls
Yeah.
through smartphones today anyway. So that's not good, but that's gonna be the only thing. So yeah, we got our and here in Houston we have the most advanced CAD that was built in the 1990s. And so yeah, so one of our challenges is getting our archaic CAD to be able to do the things that we need to do in a modern world. I'm not
Right.
kidding you. Our
Yeah.
CAD is like 30 years old.
Yeah. Yeah. And there are lots of newer CADs. It's a big expense, capital expense.
Tanner, what was
Um,
your first question? I'm sorry, Peter.
So you gave us some statistics about how, the paramedics are clearing the scenes,
Oh
40
yeah.
faster, they have more time available. Do you have any sense, did that improve response times specifically to high priority medical emergencies like cardiac arrest in your community?
Yeah, so if our assistant chief was here, he'd be able to answer that question more specifically for you. What he tracked was unit hour utilization of the heavy apparatus. And what he and I, so we've got 4 shifts. These guys work in Houston, 24 on, 24 off, 24 on, 5 days off. That's the rotation here. And so we got 4 shifts, A, B, C, and D. And so the A shift was using Ethan more than the other shifts. And so the chief was able to measure that the unit hour utilization for the heavy apparatus across the entire city was lower on the A shift. And then when we looked at those fire districts, which were even more aggressive with using Ethan, they, even within that shift, they were able to see the disparity of how much the unit hour utilization of the heavy apparatus went down. The ambulances went down some, quite honestly, but not a whole lot. And again, that's because we're using the fire trucks to fill that gap now. So you're first going to see it on the fire trucks before you see it on the ambulances. But that's the number. I can't tell you what the number was, but that's where they measured it.
Thank you.
David, when we look at the state of Florida and we look at what agencies, to potentially target, or should we be looking at the agencies that are kind of have some evidence of overwhelm, if you will, as opposed to those agencies who, they're seeing 40, 45 calls a day amongst 8 stations, and
Yeah.
they don't have that pain, if you will, that maybe Houston has. What are your
So
thoughts on that?
Yeah, my thought is that the communities that have got the lower call volumes might be a greater risk for having a robust alternate transportation system and other destinations to bring people to. So your higher call volume areas, your communities that got higher call volume are going to be probably a little bit more densely populated. They're going to have more urgent care centers, they have more freestanding ERs, more of that. From my standpoint, the only rate limiting step is, whatever community we go into, you got to have an Uber or a Lyft or something like that, and then you also got to have we could look at if we just put them in the cab and send them all to the ER, that would save the local EMS provider a lot of operational things. It's not going to save the third party payers a whole lot, so that makes it more difficult for us. But we can still work with that. But it would be really helpful if they've got urgent care centers something along that line that we could send people to that would be lower cost to the third-party payers.
And just I'm not sure if this has been a piece of conversation, but until the third-party payer does kick in, is there the ability of going to the state and saying to the state, this is saving you, tens of millions of dollars. Can the state kind of initiate the process, let's say for 6 months to a year, until you get everything else going as a bridge?
Yeah,
right?
that would be a perfect world. If we get the state to come in and make it available to, they define who they want to make it available to everybody. Again, our operational thing will be alternate transportation, alternate destination, right? But to everybody who's got that, then that gives us the time to build the business argument to go to the third party payer. Say, look at how much money we're saving you. You need to give us a slice of this, or and just threaten them, or it'll go away. And you can go back to paying through the nose. Because when we talk to them, most of your third-party payers, what they focus in on a lot right now is their high utilizers, which are our high utilizers. What they are shocked to find out is that they're not high utilizers, are still costing them a ton of money that they don't need to be spending. When we show that to them, that was off their radar. That Peter Entebbe, who calls once every 3 years, but he's still spending over $2,000 on an ambulance ride that should have cost $15 for an Uber to go to a $1,500, $2,000 emergency department visit, which should have been a $300 urgent care visit.
Correct.
Yeah, we point that out to them. You should just see the blood drain out of their faces. Really?
Yeah, it's fascinating that when you look at the economics of healthcare and how much we're spending, when you just look at the total healthcare spend in this country, and I think it's quadrupled compared to the GDP, the increase in GDP. So like this whole healthcare spend is untenable over time, right? And it's mind-boggling that you guys have been doing this, what, 11 years?
Over 10, yeah.
Over
you go
10
back,
years.
If you go back to the nurses, it was 2008, so almost
right.
one. Yeah.
Right, and at least now, I think you have all the pieces in place for there are less hurdles to overcome on our end. I think there's a couple hurdles that are on your end that you have to have more volume, and that's why I'm thinking get the state involved, right? Get some bigger agencies where there's some volume involved. How long do you see a pilot lasting? Like, for example, if you say to Palm Beach County Fire Rescue, hey, we want you to pilot this thing, and then after X amount of months, we'll tell you we can evaluate the savings. How long do you think that looks like?
Yeah, so Gaby is our numbers person, so I'm going to give you an answer that I reserve the right to change once Gaby says, no, that's not right. But I'm going to think it's going to be about a year. And the reason I say that is, Peter, you know me, we've been friends for a long time, and I tend to be two things. I tend to be brutally honest, and I tend to be a realist. So let's say we were to go into, you mentioned Palm Beach County. On day one, your firefighter EMTs are not going to all jump on this and use it. They're going to be skeptical. They're going to be those. They're going to be quick adopters and late adopters. And the quick adopters, something's going to go wrong. They're going to have the connection wasn't great, or the Uber took too long to get there. There's going to be, and then that's going to spread like wildfire about why this thing doesn't work. And we'll have to get through those early road humps before we get the mass, the shift in the people. I'm obviously a big fan of Ethan. But it's a good tool, but is it going to be perfect? No, there are going to be some things. It's the 98%. I say the 98% rule. 98% of the time, Houston firefighters do the job right the first time. 1% of the time, they make an honest mistake, and 1% of the time, they need to be retrained, reassigned, or retired. And then so we joke here in Houston about the 98% rule, but the point is, nothing is 100% perfect, and it's not going to be 100% perfect day one. So I would say a year. Again, it's going to take each community some time to kind of kick the tires on it, get a comfort level before they start really using it. Well, that's what I need. I need them to be really using it at a volume that I can then go to Blue Cross Blue Shield and say, pay up, pal.
Yeah. Well, I can tell you everything I've heard, and I'd love to hear Tanner's final thoughts. Everything I've heard today makes this a statewide type of effort where the state, just like we're doing for whole blood, the state's going to say, if you qualify and you want whole blood, here are the things you need to do, and then we're going to provide it to you, and that way the state has all the data, because the startup costs are really more time and labor limited, like we have to upload all the stuff and so forth. It sounds like it's not going to be that big of a lift. Yeah.
The other thing to keep in mind is, we're going to be paying the doctors. So our startup costs and getting the computers all lined up and pre-programmed, there's that. But then I got to be paying the doctors every day. And, so if we get the state, if that's possible, that's what that money will be going for, be to support the doctors. And the other thing is for the physicians that may be on is that you do this from home. Okay. So, so you do it from the comfort of your own home. But I'm paying you while you're sitting there. I'm not paying you per call. I'm paying you per hour.
Yeah.
And,
yeah, I know, Chris Souders, when I came to visit you guys, he was doing it. He loved it.
Yeah.
Very simple. Dr. Parmar, go ahead, Janil, one of our EMS fellows.
Hello, thank you very much, sir. I'm driving, so sorry I can't turn my camera on, but you can hear me?
Yes. Yes.
Yeah, go ahead. Yep.
Yeah, thank you, sir, for the presentation. The company sounds great, and it seems like, for all the reasons that we described and Dr. Antevi said, I think it could very well work in Florida, where we are. As a physician who potentially could work for you and the company, and as a EMS director for one of the fire departments here, for example, the case that you had earlier where the left hand pain, right, that was radiating to the upper forearm. Let's just say, yes, it was very simple, and almost 99.99% of the time, this is going to be nothing. But let's say it turned out to be a STEMI. Patient goes, the case goes in the wrong direction, and there's a litigation. Does the company provide malpractice, and is the physician involved, or is my fire department involved?
Yeah, so the medical decision making by the physician. We provide medical malpractice coverage for our physicians that are working, Ethan, for their decision making.
Yes, sir.
Okay. Oh, good. Okay, that's important. That's important. And that coverage is going to be provided by the LGC.
That's correct.
For wherever. Okay, very good. Anybody else? Any other folks who want to unmute themselves, ask a question? Got something in my eye here.
So one thing I'm going to brag a little bit. So we've got 40,000 patients. We've not had any bad outcomes yet. We had Gaby referred to the one case, and I was actually on that case. So a lady called from a bus stop with her suitcase, and she was a Greyhound cross country bus. She came from, I can't remember where she came from, someplace out of state to Houston, and she wanted to go to a hospital south of where she was. And so I said, well, the closest hospital actually is, north of where you are. And she's like, okay, fine. And when the cab driver went to take a left to go south, she told him, no, I don't want to go that way. I want to go the other way. Mm-hmm. So she didn't want to go to the hospital. She wanted to go home. Yeah.
Yeah.
We did have one guy, and we had one other case. We did have a guy who was a frequent caller, if you will. He called a couple of times and got Ethan. Oh my gosh, it's funny and hilarious and infuriating. He was an employee at the hospital, and he would call and complain he had, a minor problem to get a free cab ride to work. So we figured that out and stopped servicing him. But yeah.
If you work right next to the hospital, yeah. So I'm going to bring in Kim Landry. So Dr. Landry, if you're still there, if you wouldn't mind, just a last question. You have probably the most experience in the state with telehealth. Hearing everything that you've heard today, are there any barriers that you see or any thoughts you have, since you've been doing this for a long, long time as well?
Yeah. So again, my experience with EMS telemedicine and being able to have an EMS crew on scene, bring a physician in virtually for that patient. In my experience, it has really basically improved the morale and the the paramedics' confidence in their ability to go in with a kind of questionable situation and guide them through a more advanced physical exam. And one of the kind of prime examples I had is they called me on a case that they thought was just a benign positional vertigo. Patient basically was having dizziness, kind of somewhat associated when she stood up or moved. And we went through a little bit more of a detailed neurologic exam, and the concern was actually more that she was probably having a posterior stroke. And so it kind of it taught the medic, a good lesson, and the patient was certainly thrilled about it because I think it did end up being a posterior stroke, evolving posterior stroke on this particular patient. So it's just when you look at it globally from a paramedic's perspective, when you're helping them do a more advanced exam on these patients, and the patients and families that are there witnessing this, that are absolutely appreciative of hands being on the patient as opposed to just asking questions and just jotting notes down, that the patient satisfactions, are just through the roof, and the paramedic satisfaction is through the roof. So it's a win-win-win situation at all because you end up converting a lot of high-risk refusers into being transported to the hospital, and by the same token, you also help these people that don't have serious problems if you can able to prescribe their prescription to them to start their treatment at home with follow-up instructions and stuff. It's just it's really, you can't lose from it. So the part that gets to be the difficult part is the financial part of it, is who pays it and how you get paid, et cetera, et cetera. So ultimately, when that's resolved and satisfactory, there's just no limit to what we can do. And boy, if you throw in digital diagnostic equipment, otoscopes, high exam cameras, I mean, there's so much more to the differential diagnosis that you can add with these exams in the patient's living room. It's just going to increase even more the efficiency and kind of reduce the risk to the physician by being able to perform such detailed exams at the bedside in the patient's home.
Yeah, you mentioned something I wanted to add is that currently we don't record these interactions. We did back in the day when we first started, but the storage is just crazy expensive. So we stopped doing that. We're moving towards a platform where we're going to be recording and keeping for 6 months, rolling every day. And that way, if we have a case that is either a good teaching case or there's we're concerned that there might be a bad outcome case, we'll be able to pull that and save that permanently. So again, to the liability case, should we have a case where it goes badly, we will, assuming the doctor, did their job right. I mean, we're in medicine. We're the least exact of all sciences, right? Every physician on here either has or will have the day when you send somebody home who, for all intensive purposes, had nothing wrong with them, and then they're going to die, and they're going to come back and say, you should have, they came in with a twisted ankle, and they go home and they have a hemorrhagic stroke, and they're going to say you should have predicted it, right? But we will have the interactions recorded shortly here. And like I said, our plan is only keep them for 6 months to keep our costs down, and then pluck out of that good teaching cases or just sit on the ones that we have some reason to worry about, which, the best thing is that our EMTs now are so good at screening what is appropriate for Ethan. And the volume is so big, right? I mean, it's just,
Yeah.
yeah.
And Kim mentioned something that I thought, and Lou Steinberg had reminded me to talk about it, which is these devices, including ultrasound. And where do you see that? Where do you see these otoscopes? And now there's a new Kiku stethoscope that records sound that has AI in it. What about the ultrasound? Or do you see this as not for this type of patient? What are your thoughts there?
So, here's the other thing. Right now, we're using Ethan in Houston for the low acuity cases to get the ambulances back in service. When we start adding these extra features, we're starting to get more into the, MIH sort of situation.
Yeah.
And that's fine. We're fine with that. You need physicians to help you with that, emergency physicians. There's no reason we can't participate in that too. We'll need to figure out how does the finances of that, like how do we recoup some sort of a coverage for that? But there's no reason we can't. Yeah, absolutely.
Wow. Okay, very good. All right. Well, we've gone over time, but this is why I wanted to do it. I wanted to get at all the questions and I think that at the state level, We have a lot of great EMS people at the state who are looking at this exact problem because they know they've already done the math of how much money these kind of non-acute patients cost the state. They know it. They have it. It's very clear which patients are insured, which are uninsured, how much of those uninsured patients costing them, Medicaid patients, etc. And it's not a small number.
Yeah. So Peter, I want to close up with a couple of things. One is that, again, I said earlier, I'm an Ethan fan for obvious reasons. Is it the best thing that will ever come down the road? No, I think it's personally, and this is my bias, I think it's the best thing that's available today. And we're going to try to change and roll with the punches and evolve as we need to. But I dare say 5-10 years from now, there won't be an EMS system across the nation that isn't doing something like this. The current model is not sustainable. It's just not. And if for no other reason, so here at the Houston Fire Department, our guys are burned out. They are exhausted, and they're sick and tired of going on calls that don't need them. It's the burnt popcorn in the microwave equivalent, right? The firefighters hate going on those burnt popcorn calls, right? It's just irritating. Well, this is the medical. It's the same thing. It's just the difference is if you're on a fire truck, you may go on that once a week. On engine one, you may get that call once a week, right? On ambulance one, you're doing it 7, 8, 9 times a day. And I really worry about, I remember back in the day when I was doing that. I had 10 years experience on the street before I went to med school. I remember how frustrating that was and how to consciously keep my emotions in check, right? It's just not the current model financially, operationally, and emotionally is not sustainable.
Well, I'm glad that you mentioned that because we just in Brevard County, one of my agencies up north, and I think Dr. Ford was on the line earlier. Let me see if he's on now. Yeah, he dropped, but he was on for the entire presentation. We had a big problem, and we said, you know what, we're going to start having our ALS and medics go there. If it's a BLS call, we're going to bring in a third-party BLS provider. And the union got upset and the whole thing. So we just put out a survey, and I just got the results yesterday. And if you read all the comments, because it was like I have the numbers in front of me, 72.46% said, do not ever take this away from us, right? Like, please, and this is about 500 medics. And when you read the comments, it's exactly what you just mentioned, which is that we don't have to deal with taking these calls that just are burning us out and dragging us down, right? Then you had a few people who their idea was, let's get more ambulances so that we don't have to get the third party involved. So like you could just see that there's some people who still think that the answer to these problems are more $1 million pieces of machinery and more shifts and more people to throw at a problem that does not require an ambulance or a transport to a very expensive hotel.
Yep.
So very, very interesting. So as far as next steps, David, let's you and I continue the conversation because, the state of Florida, we meet quarterly, and I think that the more the state, and I know Dr. Shepke knows about this already, et cetera, but I know that the state is actively interested in figuring out how to solve this problem. And at the same time, if there are people on this call today who are larger agencies, and I know we had a couple people from large agencies on here, I think that we ought to continue to see if they have interest in piloting. So my last question, just to end it, just so I'm clear, is if one large agency came to you and said, let's pilot it and use our doctors, forget about paying for other doctors, is that an entree into using it on a more local level, piloting it without the burden of the cost of the physician to you guys?
Yeah. So the global answer to that is yes. The details will work out with Gaby, but yeah, we're not, we want this to work, whatever it's going to take. Again, our current model is not sustainable. It's going to break. A lot of people are going to get hurt in the meantime. We have my opinion, we have a moral obligation to figure out how to make this work. And like anything else, the first couple of times you make the light bulb, it ain't going to shine so bright. So we'll figure it out though.
Yeah. Because
I'll be happy with the dim light bulb, Peter.
Yeah, exactly. Because then you get a high performing agency that rolls it out, not a lot of cost, medical directors, heck, I'm on call 24/7 anyway. We have a big team, Janelle Moshe is on. We have a whole big team of people who can take the calls anyway. And then we can at least start to kick the tires and then we can then promote it from the ground level saying, hey, look, we're using it. So
Yeah,
all
the
right.
other thing from your EMS physician standpoint, if those, because we got, as you know, Chris Souders and Kevin Schultz and I do it. It's hard to get out on the street when you got a family and spend time in the fire station, and which we try to do. This is another way of doing that. If you are interacting with your people, they recognize you, and now you're getting to see
It's the
them.
best.
I mean, you're seeing them live and in action, and you're part of the team. It's great.
During the Brevard issue that we said, because the union was upset at me, I agreed to take every single we call it treat and transfer. And so it was myself, Dr. Ford, Dr. Lee, and Dr. McPherson and Dr. Pepe. We took 2,500 calls over a 4 or 5 months. It stopped. We stopped it in October. But the best thing about it was that because I'm not local there, I spoke to so many of them all the time. It was the best. It was the best, and that's why we love taking the call. So that's a great way to end it. So, Dr. Persse, thank you so much. You and your team are doing great work, and I think we just need to continue the conversation because I agree with you that this is not it's not an if, it's a when, and we got to start thinking about it now. So, thank you so much for your time today. All right,
Thank you, everybody.
bye. Thank you, Tanner. Thank you so much. Good to see everybody. All right, I'll put this up on YouTube.